Okay, it has started.
Thank you very much. So again, good afternoon. My name is Lisa Emerson. I use she, her pronouns, and I am a senior policy advisor with the Division of Financial Regulation. And again, thank you for joining us today. Pretty soon, my colleague, Brooke, will be joining us, and she will introduce herself when she steps into her part of the agenda. But today is RAC number 2 for our House Bill 2002 Gender-Affirming Treatment Rulemaking. And we're going to just start today with, we're probably not going to go in depth into introductions of our RAC members, but I am going to start to display a PowerPoint here, and we'll kind of walk through that, talking about housekeeping and expectations and that sort of thing. The last RAC, there was an opportunity for our RAC members to introduce themselves and share a little bit about themselves. The recording of the RAC is on our website. If any of you who are joining today are interested in taking a look back at that. But again, we really appreciate your participation, and we do have a slide that will display all of our official RAC members, and we'll move forward once that gets displayed. So you want to bring that up, Karen, that'd be great.
All right.
Okay, so here you can see, just similar to the last slide deck we had in the last RAC, that these folks are our official RAC members, and we very much appreciate your participation. And when you can go to the next slide now. So just some housekeeping and expectations. Feel free to keep your camera off, or we would like it if you wanted to bring your camera on if you are going to speak or make any comments. It just kind of helps with the diciness of the bandwidth of Teams. So if you could please also keep your line muted if you're not speaking, that also helps. Very much helps if you could raise your hand and we could call on you in order before you speak. That's also very much appreciated. Feel free to use the chat. It is open for you to share comments along the way. I would like to impress that the initial discussion that we're going to have really is limited to RAC members and DFR staff. So there will be an opportunity for public comment where other folks, interested parties, will be able to share their comments, their verbal comments. In addition, we will also be requesting written comments from RAC members and interested parties as well. But we'll get to that part in a little bit. I just wanted to also impress this part about language, just everybody be conscientious about terminology that you use and language that you use. A very helpful resource, if you should a lot of you be aware of it, is there's Appendix B in the WPATH 8 Standard of Care Guide, has a lot of helpful terminology that you may find helpful. And also just know that this meeting, we're meeting in good faith, and let's just use honesty and sincerity when we're working together. We can go to the next slide. So we're going to start out with, Brooke is going to come on and she's going to begin discussing what some of the outstanding issues that we are aware of from the last RAC meeting. And then we'll get into reviewing the other parts of the rule that we weren't unable to get to at the last meeting. So welcome you to come on, Brooke, and introduce yourself, and you can get things started here.
Hi, everyone. My name is Brooke Hall, and I'm a senior policy analyst with the division. And I wasn't able to be at the last RAC, but I will be helping Lisa with this RAC process now that Michael is no longer with us. And Karen, if you can move forward on the slide deck. Okay. Oh, is there a slide missing? Did you go? Is there one back? There we go. Okay. One of the things that Michael did prior to leaving is he provided Lisa and I with an overview of some of the issues that need further clarification in the rule or need further discussion at the RAC. And my goal for today was really just to confirm with all RAC members that this list is accurate and as comprehensive as possible. And just for clarification, I'm not intending to get into a prolonged discussion or debate right now about any of these issues. Really, my goal is to confirm this list, and then Lisa and I can start scheduling these conversations for further RACs and start determining how we're going to modify the rule based on those conversations. So I'm just going to go over the list, and then at the end, I'll provide some time for people to comment on what is missing from the list or anything that they believe we've already covered and maybe doesn't need further discussion with the RAC. So any questions before I get started? Great. So the first issue is the definition of accepted standards of care. The current draft rule does point to the WPATH 8, and we have received some feedback that the current definition in the rule may be too limiting, or there may be other standards that we should look at. In addition, I think there is some questions about some of the procedures that are listed in the WPATH 8 that may be at this point in time considered experimental or investigational, and how insurers should be looking at those considering they are currently in the WPATH 8. The second issue is around cosmetic exclusions, and the question is really how we distinguish between gender-affirming care procedures, which must be covered under HB 2002, and other cosmetic procedures, which generally may not be covered currently. Next is enumerated procedures. So HB 2002 does call out several procedures specifically, including tracheal shave, facial feminization, electrolysis. And the question is really, do these need special attention in the rule? Next is the definition of a gender-affirming treatment provider. And this really has two segments to it. So the first is for the purposes of the requirement that a carrier must have a denial reviewed and approved in advance, exactly what types of providers can review what types of claims. What does a provider with experience mean? Again, that is provider with experience is language in the bill. And so how do we clarify that so that we are having the right types of providers review these denials? And then the second is for the purposes of network adequacy, exactly who is considered a gender-affirming treatment provider, because the bill does require carriers to have a sufficient number and geographic location of providers. And so what does that mean, and how do we measure network adequacy for the purposes of gender-affirming treatment and care? And next slide. And then for adverse benefit determinations, there is currently an ORS, which gives a definition of adverse benefit determinations. And so is the division's current statute and rule in regards to adverse benefit determinations sufficient, or do we need further clarifications within this rule set? And then the last I already talked about a little bit, but it's related to network adequacy. So what does network adequacy mean as far as gender affirming care and treatment is concerned, and how exactly do we measure that? And then there also is an outstanding question about unreasonable delay and what constitutes unreasonable delay in this context. So that's the current list I have. Does anybody have any comments, suggestions, thoughts about that list? Rick.
Thank you, Rick Blackwell, Pacific Source. I would add to the list, I think it's kind of a structural issue. I want to make sure that we're drafting just what we need in order to amplify the statute. And the way the first draft was done was really kind of mixes the statute and the rule together, which can be difficult to parse out just what the division believes is necessary to amplify the statute and what the legislature already passed. And I think just for clarity's sake, maybe the second, the second or third draft can look a little bit more like what the division's thinking, just in terms of rulemaking.
Yeah. Thanks, Rick. I appreciate that. Any other thoughts? Does everyone believe that this is a comprehensive list and that nothing needs to be added or removed? I don't think you need to just give me a thumbs up if you believe that's the case. I'm not seeing any thumbs up, which leads me to believe that maybe we need to have further discussion about the list. Or are people just very quiet today?
Hi, Brooke. This is Scott from Moda. There were some thumbs up. I saw them
Yeah.
on the screen.
Oh,
No,
maybe I'm just not seeing them.
no worries.
Thank you. All right. Well, if anybody has a light bulb moment after the RAC, you're free to send me comments or any further suggestions, and Lisa and I will go ahead and take a look at that. And I'm gonna send it back to Lisa to review the second part of the rule, which we didn't get to last time.
Thank you, Brooke. So Karen, if you could pull up the draft rule, that would be great. And go to section 3. So we're moving fairly quickly through our agenda, but what we'll do is at least get through the text, of section 3 and 4 of the draft rule, and then perhaps we'll have time to circle back to some of those other outstanding issues that we were, discussing the last RAC. But also, like as Brooke mentioned and I mentioned earlier, we're going to allow at least we would like to receive written comments on all aspects of the draft rule, which we didn't request at the last RAC. We had only received written comments related to the gender-affirming treatment bulletin. So we'll be looking forward to those written comments as well, and we're probably going to allow a couple of weeks for that. So if you could scroll down to section 3. There you go. So this has to do with the topic of adverse benefit determination. And similar to what Rick just mentioned, the rule, the original draft rule, in essence, follows the statute very closely, the statutory language. And we are looking to you as RAC members and also interested parties when we get to the public comment period to kind of weigh in on what else is needed to, as Rick mentioned, further clarify what isn't in the statute or amplify the statute. So this is fairly straightforward. As Brooke mentioned, we already have there's a statute 743B.001 that explains what is already considered in law an adverse benefit determination. So in essence, it's really, we're just stating what's already in House Bill 2002 here. And want to open it up for comment from RAC members on whether additional information is needed for this section to help us further define and clarify the topic around adverse benefit determinations. Does anyone have any thoughts? Any RAC members have any thoughts that they'd like to share verbally on this matter? Why don't we start with Jonathan? He's first up, and then we'll go down the line.
Thank you. Jonathan Broxhike with Cascade AIDS Project. I think we, along with other advocates, are concerned that this part of the rule does not ensure that the provider reviewing an adverse benefit determination has the appropriate expertise to do so. we don't want to get into a situation, and I think this was the legislative, let me back up. The legislative intent, I think, was that a provider with expertise in gender affirming care would be reviewing those determinations. And I think we could add some specificity to the rule language. I know that other folks, and I'll let them speak for themselves, but other advocates have done some consultation with national leaders in gender affirming treatment and determined that one good benchmark would be, or a minimum benchmark would be requiring the provider has completed a GEI training course, which is offered by WPATH. And also another suggested edit would be changing, let me get this right, changing the final part of the first sentence of this rule to, and I can put this in the chat, but to can demonstrate experience relevant to the gender affirming treatment. So rather than simply with experience prescribing gender affirming treatment broadly, requiring that that provider has experience relevant to the gender affirming treatment. So for example, we wouldn't want a provider who, we wouldn't want a behavioral health claim perhaps being reviewed by a specialist of some kind in physical health, just making sure that the provider's qualifications match the claim that's under review. That's it.
Thank you, Jonathan. Let's see, I think we had some other hands up that have gone down, maybe that you helped cover some of that information for the advocates. Let's move to number one I see is Antoinette.
Yeah, hi, Antoinette Ewachi from Cambia Health Solutions. My comment is around 3B about excluding for cosmetic, or we can't exclude for cosmetic services. And it includes, of course, a list of those services, and it's not limited to those services. And we understand that's straight from the bill, the legislation. But I think it would be great to clarify how to deal with some of these experimental treatments under WPATH 8, especially those that present patient safety concerns, because of course that's also our number one priority here. An example of that is uterine transplant. It's currently considered experimental. So if should a claim come in for that treatment that is currently considered experimental, I mean, logically, we believe that it should be denied experimental, which is consistent with, current medical policies. So we would like the rules to address that, how we deal with these experimental treatments. That's also under WPATH. Especially the ones that present patient safety concerns.
Okay, thank you for your comment. Let's go to Rick Blackwell.
Thanks, Rick Blackwell again with Pacific Source. I would just note that the 2002 that's based on that Section 3 of the rule is based on does require us to refer this to a provider with experience prescribing or delivering gender affirming treatment. It might be that some of unlocking that is just how the division defines gender affirming treatment. It's not specifically called out that you're to pick the provider with experience in that particular service, but I hear what you're saying, Jonathan. So maybe it's within the definition that can be resolved.
I think that's something for us to definitely consider. Thank you for raising that, Rick. Yeah, we're going to, take all this information in. It's helpful to us as Brooke and I continue to work through this with our other DFR colleagues as well. So we appreciate receiving all this feedback. Does anybody else have any other thoughts they want to share around this Section 3? Okay. Let's go to Erin. I saw your hand up. Do you want to say anything?
Yes, just to note,
Okay.
as we're talking about things that are experimental, HRT was considered experimental for a while, and that was the basis for it being denied to folks. And so we're trying to get past those fundamental hurdles here. I know, and then the fact that the uterine transplant has come up several times seems to be a big concern for folks. But I just want to be careful with how we're using language in terms of experimental, that's all.
Thank you, Erin. Okay. So hearing no more comments here, let's go ahead and get through the rest of the draft rule. So this is section 4, and it has to do with, we're getting into the topic of network adequacy. And so again, this is pretty much pulling the key pieces from the bill into the rule. And we'd like to hear from RAC members, what other information might we want to add to this section of the rule to provide greater clarity? I recall one comment was raised about what does unreasonable delay mean? And would be interested in feedback on that from RAC members as well. So does anyone want to go first at sharing their thoughts about this section of the rule? Once you have a minute, just revisit it. Okay, we'll go to you first, Antoinette.
Yeah, just a general comment, because we just want to make sure that the DFR understands that there are some patients that may not have, geographically close access because there really are no providers available for GAT services. And, we just want to make it clear that also providers must meet, insurers' ordinary credentialing and quality control metrics. So, we can't be required to bring a provider into our network just because they provide, GAT, if they don't meet, insurers' other ordinary standards, of care and metrics.
Thank you for that feedback. Let's go next to Seth.
Yeah, I'm going to put some suggested language here in the chat, just pointing to ORS 743-505B, the factor-based approach, just applying that here to HB 2002. I think it's important in our thought process as advocates to look at least being able to establish, in speaking to your unreasonable delay question, like enrollee wait times and understanding the median for our certain areas. And understanding also the evidence of having the full range of gender-affirming treatment providers, potentially through narrative, would allow DFR to understand the carrier's amount of providers. And there could be specificity here in the list of fields of which we see gender-affirming treatment taking place. And so I can also put that list here below of where we see those providers existing in our networks.
Thank you, Seth. And if after the RAC members have an opportunity to review what Seth has put in the chat, feel free to comment on that as well. But I'm just going to continue to kind of go in order of hands that I see go up. Let's go to Rick Blackwell.
Sorry, keep talking.
That's okay.
Did the network adequacy rules ever define unreasonable delay? I was looking through 836.053. Division 53, and I can see where the term has been used, but I don't think it's ever been defined. Maybe it's because it's a factor-based approach and is difficult to define. Yeah. So maybe just a call out back to those rules.
Yeah, I welcome Brooke to chime in here, and I was going to mention one thing that we know that forthcoming are some quantitative standards for behavioral health and specialty care and primary care with the 2025 plan year for qualified health plans. And I don't know if some of that might factor in to this in the future, but go ahead, Brooke, if you want to give your comments to what Rick's question about that.
I was just going to say, no, there is not currently a definition of unreasonable delay in our current rules or statute. And just for people's knowledge, we did introduce a network adequacy statute in 2023 that would have made some additions to our current statute, including adding quantitative standards that did not pass, not due to reasons for the substance of the bill, but we may bring that back in 2025, although our legislative agenda is not yet set, so I can't say that with any certainty, but we may bring that back in 2025.
Thanks, Brooke. And I should clarify that those standards I referred to are the federal CMS rules related to the timing for network adequacy. Okay, I'll just continue to go in order here. Jonathan, let's go to you.
Thank you. Just wanted to +1 the language that Seth shared. CAP supports that language. It's really intended to mirror language that already exists in rule for when insurers elect to demonstrate compliance via that factor-based approach. So it's really not doing anything too different from how network adequacy is judged in other cases. The one piece that there are other, this also mirrors language, but it's maybe a little specific to gender affirming treatment, is in the last subsection of that language. And Seth shared a full list of subspecialties, but just wanting to be sure that in the insurer's narrative that they provide, that they speak to the range of gender affirming treatment providers. Again, since gender affirming treatment is taking place in a number of different specialties, wanting to be sure that the narrative that's provided would address not just, say, surgery or mental health, but also, you know, hormone therapy, endocrinologists, that kind of thing. That's all.
Thank you. And that's an important point. Let's go next to Amy.
So this is thank you. This is more of a nuanced issue that I don't know where it fits, but from a perspective of a healthcare provider, one of the things that I get concerned about when we're talking about network adequacy and allowing individuals to have a broader access or a network to be expanded, if that results in individuals traveling out of state for, let's say, surgical services, that we recognize that many of these surgeries may be multiple stages with different periods of time for recovery between those stages. And I don't know if we capture this in rule or how we attend to this to ensure that when someone is going out of network, it kind of falls between the adverse benefit determination and the network adequacy. If someone is going out of state for care for a multiple stage procedure, that the expectation is that the entire duration and care plan extend for the entire duration of the procedure, as opposed to someone having a first stage out of state and then coming back with an expectation that subsequent stages happen locally. So I don't know how to capture that, and I can continue to think about language to represent that. But there are many surgeons in Oregon that would not likely deliver a second stage or a third stage of a surgery that was performed by a surgeon elsewhere. So I just wanted to name that for us to think about how we want to capture that and address that so that the patient has continuity of care safely. Thank you.
Thank you, Amy. Does anyone have any thoughts that they want to, any response to Amy's concern that she's raised? Any input about the current landscape of gender affirming care providers in terms of from a network adequacy perspective? Yes, continue to ponder that, and we definitely welcome written comments, but if you have something verbally to share, Jonathan, we appreciate that.
Yeah, that reminds me that maybe this is obvious, but going back in response to Antoinette's comment, section 4B of this proposed rule, which just echoes the language in the statute, is the section that's intended to address that concern about networks not being able to include the full range of providers. We have a workforce development issue alongside the network adequacy issue. And so that's why that section 4B exists, is that insurers can simply opt to cover treatment out of network rather than, being forced to bring somebody into their network for whatever reason.
Okay, thank you. Any other comments on this section? Any questions? Okay, hearing none, we'll go ahead and just pause on this piece now. We've finished the review of the draft rule, and we'll look forward to reviewing all your comments you've shared today, but also we would welcome all those to be provided to us in writing. Would be very helpful. Now we're going to move on to, we did overview of outstanding issues already. So with some of the things that Brooke just highlighted that we know that are issues that we've flagged, does anyone of the RAC members have anything that they'd like to talk about today related to those? We can bring that list back up. Or we may soon be moving to, and I just consider that the open discussion on the issues to address. And let's go in order, starting with Rick.
Hey, Lisa, I wanted to raise again on accepted standards of care. We did support, at least in the on the OHP side of things, WPATH 8 as the standard that HERC should look at. I'm just curious about the phrase "without limitation." I'm just curious as to what we're trying to get at with "without limitation." If it's that whatever revisions that happen to WPATH 8 get integrated into the rule, I think we'd have a constitutional problem. But if that is different different use or standards than WPATH, I'm trying to get at that. What's going on here?
Okay, can we pull the rule up into that for that section? It's up at the top.
Okay.
Oh, I don't think it's in.
All right. So here's
right here.
one.
1B. Is that what you were referring to, Rick? What piece were you referring to? Was that the
Yeah,
bill?
that's correct. So like right after includes, so at a minimum and without limitation. I'm just trying to figure out what that clause does for interpretation.
Well, this is the initial draft that we have, and I think we were wanting to ensure that we can allow for other evidence-based, clinical information to be included, but the WPATH 8 is the standard of care for transgender and diverse people. So we'll take a look at that, but I don't have anything I can immediately share about that. That may be something that we were looking at Washington's rules and trying to kind of be consistent with their rule as well. But we'll take that back and take a closer look at that. Does anybody have any thoughts on the topic of the standard of care definition? And again, you can follow it up with your thoughts in writing. We would appreciate that. Okay, I see some hands. Let's go to Glenn Bailey. And if you
Yeah,
can't
I
raise
was
your
just,
hand, feel free to chat if you can't raise your hand that you want to make a comment if you are a RAC member. Go ahead, Glenn.
I just want to, more than anything, I want to confirm what I'm thinking is what the intention was. In this phrase under 2, you say, you know, or impose additional cost sharing or other limitations or restrictions. So I would assume what is meant by additional cost sharing is you can't have additional cost sharing specific to gender affirming care, but you certainly can have cost sharing for, say, surgery overall. That's could be different than other forms of treatment.
I think it's to make sure that there's parity, that mental health parity is observed where treatment isn't, cost sharing isn't discriminatory for someone receiving surgery related to gender affirming treatment purposes.
So it's just that you have one, if you have surgery cost sharing, it just applies to all types of surgery.
Correct. We're going to be looking back at the mental health parity law, federal and state. Yes.
Okay.
But we want to make it clear in these rules as well. Just, restating this for clarity.
Okay. Thank you.
Let's go to Jonathan.
Thank you. Just want to affirm that CAP supports identifying WPATH SOC8 as the accepted standards of care. No opinion about the without limitation language, but we do think it's a good idea to tie accepted standards of care to WPATH SOC8. I'll also take this opportunity to try to respond to a comment Antoinette made earlier, and it's come up a couple times about procedures that aren't, that aren't commonplace, I guess, let's say. So like the specific example, I guess I would request that those concerns be made more specific, pointing to references within the standards of care, because I'm by no means an expert in SOC8, but quick search for uterine transplantation, it's included in a list of procedures, and the sort of preface to the list is, these include procedures that are kind of forward, we're looking forward as well as what's currently offered. But there's no recommendation in that section on surgeries saying people should be receiving this or not, or anything about the procedure is literally not mentioned in any of the recommendations. So that's an example of how I don't think the fact that a procedure is mentioned in kind of an appendix to a section would in any way require a payer to cover that. It's not called out within the actual recommendations. So if there are other, and again, I'm not an expert, but if there are concerns about specific procedures, just making sure that we're being specific about, is there a recommendation in these standards of care that's going to create complications, that then I'd like there to be a reference to that. Thanks.
And this is Antoinette. I'm sorry. I had to call via audio, and in audio, there's no way to raise your hand. So
no problem.
I'm sorry. I think a comment was made earlier in reference to something I said, but I didn't hear the comment because I was disconnected and I had to call back in audio. So if that could be repeated, that would be great. But in response to the comment that was just made, I mean, you're correct, but then how do we, how do we how do we really stick to that, like hold that, what's on the list? I think that's where we struggle with. Yeah, so you're right. Nowhere in WPATH does it say that, we are to cover that. That's why we just want to be clear that when these come up, right, and generally in the medical practice is known as investigational, that we would not be bound to cover it. So that's the sticky point. So I agree with you, but at the same time, how do we hold to that list?
Well, thank you for restating your question, and sorry about the audio problem. Did you want to respond to that? I believe it was Jonathan's was referring back to your comment. Did you want to do any follow-up on that, Jonathan?
I just frankly disagree that there's any lack of clarity in the standards of care. I don't think that this is a issue that's going to come up.
Okay, thank you. Yeah, the standard of care is a very robust document, so I would encourage you all, if you haven't spent a lot of time with it, to do so. It was really informative for me. Okay, let's go to Rick Blackwell.
One more comment and I get a free sandwich.
Yeah.
I wanted to go back to what Glenn said about the cost share, because I do think getting back to the statute and what Jonathan said earlier, I think the cost sharing was really limited to in-network, out-of-network. And I think this is an expansion of what the statute was really requiring in terms of cost share. So I would seek to strike that, or just understand what we're interpreting or amplifying here from the statute.
Okay, we'll need to talk about that. Have an opportunity to review that and get back to you. Glenn, you raised your hand. You want to respond to that? I think your hand is still up, but I'm not hearing you.
Sorry.
Go ahead.
I just want to echo what Rick said. Yeah, there's nothing in the statute that talks about the additional cost sharing except for the in-network, out-of-network. So I just wanted to better understand, like Rick said, what's the intention here, and how does this relate to the base legislation?
Yeah, we'll need to get back together, get back with you guys on that. I think it may also be have some relation to a past bulletin that the division has issued. So we'll put our heads together and we'll have to get back with you on that.
Thank you.
You're welcome. I see a couple of other hands up. Let's go to Marlene Converse.
Hi, I'm Marlene Converse from Kaiser Permanente, and I have a technical question about the reference to incorporating in 1B, incorporating WPATH 8 as Exhibit 1 to this rule. Are we contemplating actually cutting and pasting the contents of that into an exhibit, or providing like a website link? I'm just wondering if we could run into any copyright issues if we did mass cutting and pasting.
I sincerely apologize, Marlene. I'm going to ask you to repeat that if you wouldn't mind.
Hi, were you able to hear me, or was it just I spoke too quickly?
A little bit too quickly, but I was also distracted, so I apologize.
Okay, no worries. I just wanted to make sure the microphone was close enough to my face. So in section 1B, it's talking about incorporating the WPATH 8 as Exhibit 1 to the rule. Are we talking about referencing like a website or like a citation to it, or are we talking about cutting and pasting wholesale this large document into the regulation. And I'm just wondering, would that create any copyright issues that we need to be mindful of? I'm hoping this is just a technical question.
Do you want me to go ahead, Lisa?
Yeah, go ahead.
Sorry.
Yeah.
So I believe that, I mean, when Lisa and I spoke to Michael about this, his idea was to incorporate the WPATH 8, the whole large PDF file, as an exhibit to the rule. In other rule sets that we currently have within DFR, we have included those on the website and included a website link. And so really we could do that either way. I'm happy. I haven't looked into whether incorporating it into the rule would cause any copyright issues, but I appreciate you bringing up that point, and I think that's something that we'll definitely look into.
Thank you.
Yeah, and again, my apologies, I missed you in the chat here, so sorry, Marlene.
Can I, Lisa and Brooke?
Go ahead, Karen.
Hey, in response to the question, I'm Karen Winkle, the rules coordinator for the division, and I would prefer that it be a link versus, I think it's like a 180-page document, or it's quite a large document page-wise. So I know that when Michael talked with David, our web tech, we were talking about a link.
Thank you for that, Karen.
Yeah, it's 260 pages, and I see someone also shared that with us. Okay, thanks, Karen. Let's now, Erin, I want to go to you and give you an opportunity to speak.
Sure. Thank you. So I'm not quite sure if it's applicable in this space when we're talking about network adequacy, but there are some new things that came through OHA as of the 1st of this year around tier 1, tier 2, tier 3 and time and distance. And so I'm not sure if that would be relevant or not, but it might be something to look at. And then when it comes to the cost sharing, the concern that the community generally has is that an oncology patient and a trans patient should not inherently have a base difference in cost when trying to access an augmentation. So that is the place that I ultimately think we're trying to get to with the rules, is that being under gender dysphoria does not necessarily change that, though folks are welcome to chime in beyond that.
Thank you, Erin. I see that Jonathan has their hand up, so please go ahead, Jonathan.
Yeah, I want to support Erin's comment. I think that the language about imposing additional cost sharing ties back to the language about limiting coverage in the original statute. The division wanting to make sure that insurers wouldn't effectively limit coverage by requiring cost sharing for a procedure when it's based on when it's for gender affirming treatment versus when it's not. I understand where Rick and other folks are coming from, and Glenn, that I think the language could be revised to be a little more clear, rather than, like, right now it's hanging a lot on that word additional. But I do think that it's an important that it provides some necessary protection to spell that out here.
Noted, thank you, and we appreciate everyone raising that concern, that we need some additional clarity here. Rick, go ahead.
Yeah, well, thank you, Rick Blackwell again, Pacific Source. You know, when you talk about cost share as a barrier to care, though, that could apply in so many situations where insurers require cost share, whether or not it's intended to limit care or not. I think that's a slippery slope that the division should be thinking about if it wants to move forward in that respect.
Thank you, Rick. Okay, any other RAC members have any comments? Okay. Let's see. Brooke, where do you think we're at, and what do you think we want to do for some next steps here? I'm just double looking at some of the chats to make sure I didn't miss anything. So just a moment, please.
Well, I believe our next RAC meeting, we are foregoing a RAC meeting in February due to session. So our next RAC meeting won't be until the end of March, which gives everybody plenty of time to review the current draft rule and provide us with comment. So the next step would probably be for anybody who wants to provide written comment to provide that written comment to Lisa and I and Karen. And Lisa, did you have a date for when you wanted that feedback by?
Yeah, I do. I was thinking February, I believe it's 8th or 9th. Probably puts us out a couple of weeks, but we'll double check that. But we do need to also take up, we have to provide some time for public comment because we haven't done that yet. So, but I see Seth has a comment. So Seth, please go ahead.
I just had a late thought on some of the earlier that I wanted to just get into the recording.
Yeah.
The Washington rulemaking is really supportive and has a little bit more detail, as well as allowing enrollees to request and ensure identify the medical, vocational, or experts whose advice was obtained in making an adverse benefit determination. And so I'm happy to send over some of that language and just recommend that we have a very similar bill in Washington, kind of mirroring Oregon's, that has already been in place, so that there's some supportive things to look at there.
Thank you. That's helpful. So let's allow some time here for anyone, any interested parties or any RAC members who didn't have an opportunity to give their verbal comments. Does anyone want to make a public comment? Please raise your hand or put a note in the chat so we know you would like to make a comment. Okay, well, hearing none, we'll close that opportunity for public comment. And let's go back to Aaron. You have the floor.
So thank you. I was moving a little slow. I went back and looked at some of the old bulletins. And so in the 2016, there's a space that actually talks about cost. And it is under applicability of policy to health insurance. There's a section that says, furthermore, any requirements that clients seeking gender-affirming treatment pay extra out-of-pocket costs or incur expenses related to additional surgical and medical consultations that are not imposed by other health conditions are not allowed, because these requirements discriminate based on the health condition of gender dysphoria. And so hopefully I'm hoping that provides some idea of what we're trying to get at in terms of the financial parity and the additional out-of-pocket costs related to surgery or any access to care.
Thank you, Aaron. And that was what I was trying to say, but I didn't say it so well. So thank you. All right. Don't want to rush things, everyone out of here, but I guess Brooke mentioned we're going to be meeting again on the 21st of March, so we can allow time for all the busy work we're going to have during the short session. And it'll also give us time to look at all the feedback that we're going to receive after this RAC. And just to put a date on comments so we can make that clear, but we can send out a follow-up email. Let's go with looking at my calendar really quick to make sure I have the date right. Of course, Outlook wants to spin. So is Friday, February, help me out here.
Friday, February 9th is about two weeks and a day away.
Well, then let's just do Friday, February 9th. It's a good day. So we'd like to receive your written comments by then. Okay, any other closing thoughts, Brooke? Any other
no, I'm
DFR
just going to
staff?
say that Lisa, once we receive those comments, Lisa and I will review those and then make any adjustments that we see fit to the current rule set. And then at the RAC meeting in March, we will likely have a new draft rule to review with you all.
Definitely.
Or I should say an updated draft rule to review with you.
Updated, yeah.
Yes.
All right, well, we really, really appreciate everyone's participation. And I hope you have a wonderful rest of your day. We'll talk again soon.
Thank you.
Thank you.